In this PowerPoint, we're going to take a look at pediatric polysomnography. We're going to look at the reasons why we would perform polysomnography, some differences in setting up a study for a child as opposed to an adult, and some other factors that are involved. Let's go on to our next slide. The evaluation of sleep-related breathing disorders in pediatrics use the polysomnogram. That is still the gold standard for sleep disorders and sleep-related breathing for both pediatrics and adults. Let's go on to our next slide. American Academy of Pediatrics published a position paper in 2002 stating that polysomnography is a diagnostic test of choice for children with suspected obstructive sleep apnea. Other uses for polysomnography include obstructive hypoventilation in the pediatric, gastroesophageal reflux, seizures, narcolepsy, and periodic limb movement disorders. Let's go on to our next slide. Let's take a look at how obstructive sleep apnea occurs in pediatrics. Nearly 12% of all children snore on most nights. Obstructive sleep apnea syndrome occurs in 1 to 4% of school-age children. And again, the gold standard for diagnosis is the polysomnogram. In children, obstructive sleep apnea is characterized by prolonged partial upper airway obstruction or intermittent complete obstruction. This disrupts normal ventilation during sleep and the normal sleep patterns. The risk factors for obstructive sleep apnea in pediatrics includes anything that's going to affect the size or compliance of the pharynx. This includes problems with the tonsils when they're enlarged, obesity, disorders that affect the muscle tone, and also craniofacial and neuromuscular disorders. Let's go on to our next slide. Treatment of obstructive sleep apnea in pediatrics is different from adults. Our first line of treatment in children is going to be a tonsillectomy, as opposed to adults where CPAP is the treatment of choice. The apnea-hypopnea index almost always improves after a tonsillectomy, although it may not completely normalize, particularly in the face of severe disease or obesity. Some other options are going to be maxillomandibular advancement surgery. This should be considered for those kids with craniofacial defects that cause OSA. Some dental devices that reposition the jaw and tongue may also be helpful in kids. And then there's also the rapid maxillary expansion, which has been successful in some selected groups of children. If the tonsillectomy is not effective, or if there's a contraindication to surgery, or maybe it's just the patient's preference, then the next line of therapy is going to be CPAP. Common indications where CPAP is effective for obstructive sleep apnea in children is obesity, some craniofacial anomalies, persistent obstructive sleep apnea after a tonsillectomy, Down syndrome, and Prader-Willi syndrome. BiPAP may be used to deliver non-invasive ventilation to children who need it and who have more of a hypoventilation problem with sleep. Maybe it's due to neuromuscular disease or a neurological disease. So first line, tonsillectomy. Second line, CPAP. If CPAP's not doing it, then possibly BiPAP. And then there's some other dental devices that can be used, surgeries. Medications that you see listed, those would include nasal decongestants or maybe some nasal steroids to get the inflammation down in the nasal passages, which may be causing the obstruction. Weight loss, especially for the obese group, and then oxygen for any patient who has hypoxemia along with obstructive sleep apnea, where the CPAP is resolving the apnea, but the hypoxemia persists. So, rule of thumb, start with the tonsillectomy and then move on from there. Let's go to our next slide. Some of the consequences of untreated OSA in pediatric population include significant emotional, behavioral, and cognitive dysfunction. Along with this, we have the learning and behavioral dysfunction, which includes aggressive behavior, hyperactivity, poor school performance, daytime sleepiness, decreased daytime function, and decreased alertness. Along with this includes reduced verbal and performance IQ. Some other consequences include nocturnal enuresis. This actually is a problem seen in over 15% of school-aged children, which also may occur in your sleep center, but it is associated with sleep apnea. Some metabolic problems that untreated OSA can lead to is diabetes and metabolic syndrome. And then some overall health problems that OSA can lead to is hypertension, cor pulmonale, and reduced ventricular function. This can occur even in your pediatric population. However, the first line of treatment, the adenotonsillectomy, we see improvement in the learning and behaviors. We also see improvement in the nocturnal enuresis, as well as the diabetes and metabolic syndrome after they've had that tonsillectomy done. The only thing where the improvement is unclear is on the reduced verbal and performance IQ. So far, the studies haven't shown that that's improved after treatment with the adenotonsillectomy. Let's go on to our next slide. Okay, let's take a look at some appropriate times to use polysomnogram in pediatrics. We know that it is indicated for sleep-related breathing disorders and to help diagnose those, but it's also helpful in sleep-related seizure activity, sleep-related gastroesophageal reflux, or GERD. It's also useful with nighttime asthma or any persistent cough. Also with ADHD or Tourette syndrome associated with restless sleep and disrupted daytime functioning. Also with RLS and PLMS, relatively common in the pediatric population. Also with recurrent REM sleep behaviors, severe bruxism, snoring and hypopnea or apnea, which we've already identified, or any unexplained daytime sleepiness, and anytime you suspect narcolepsy. Those are all indications for PSG in our pediatric group. Let's go on to our next slide. Let's take a look at the environment for the pediatric polysomnogram. We really don't want to bring a child into an adult environment and expect them to feel comfortable and be able to have a good night's sleep. So we want to bring them into an environment that is built for them. That means using bright colors, child-friendly design, which maybe is cartoon characters or animals that would appeal to children. With the bed covers, maybe it has a fun decoration on it. Again, cartoon-like things are well. The staff should dress in scrubs that would be pleasing to the child's eye, whether it's, again, animals or cartoon figures, whatnot. All equipment should be out of sight for the child. It shouldn't be glaring there that they are here for a sleep study. You want to have that hidden away in cabinets and whatnot. Along with this, you want to have the safety cover plates over all your electrical outlets. If you're doing a sleep study on a baby that needs to sleep in a crib, have a crib there for them where your equipment can get to it easily. But again, you want to keep the equipment out of sight. This reduces the anxiety and fear in the child, and again, it makes them more comfortable and feels like the environment is built for them, not for an adult. Let's go on to our next slide. Before your night of study for the pediatric test, there's some things you want to do to prepare. First of all, it's important that we promote the child's comfort and familiarity to the sleep center. So maybe they can set up a visit to the lab prior to their test night, allow time for the staff to introduce themselves, preferably have the tech there that's going to be performing the study, and let them discuss the testing procedure with the child in terms that the child is going to understand. Make a game out of it, make it play, make it fun. Maybe you're going to demonstrate parts of the procedure on a doll or a stuffed toy, or maybe provide a video with some animation of the procedure. You want to instruct the child and parent to bring one of their favorite toys, maybe their pillow or their favorite blanket, to make the environment more comfortable for them. Also, before the night of the study, you want to identify what the home sleeping conditions are like. Then you want to try and replicate those as best as you can on the night of the study. For example, if a child sleeps in a crib, you're going to want to provide a crib. On the other hand, if the child sleeps with the light on at night, you want to be able to replicate that best you can, and so on. You want to reassure the parent and child that the parent will be close by during the study. Show them their room, show them where mom and dad would be. In some instances, mom and dad may stay in the room. The only problem is having the parent sleep in the bed with them. That's highly discouraged because you're going to pick up artifact from mom or dad moving in the bed and whatnot. But they can sit in the room. There can be rocking chairs for them, or maybe even another single bed that they could sleep in, just to make the child comfortable. It kind of depends on the age of the child, but again, our focus is to make the experience pleasant for the child and comfortable. You want to instruct the parent and child to maintain a normal sleep-wake pattern on the day of the study. If they don't usually nap, then they shouldn't nap on the day of the study. On the other hand, if they normally take a nap at 2 in the afternoon, then you want to make sure they repeat that on the day of the study. Don't try to keep the child awake if they normally do nap. Try to repeat the exact same procedures that the people do at home on the day of the study as much as possible. Let's go on to our next slide. Some other factors you want to consider before the night of study is educate the parent on their role and your role. The parent's going to be responsible for all the personal care for the child. This means dressing and undressing, diaper changes, feedings, and any medication administration. The parent should be informed in advance to bring all medications that the patient normally takes at home. Then check on any special needs. Do you need a lift to transfer from the wheelchair to the bed? Do they need oxygen? Do they need suction equipment? Whatever is needed at home, you want to make sure it's available on the night of the study and it's ready to go. When the parent is present in the testing bedroom, you want to instruct them to limit their movement, limit the lighting, and limit noise. This is to help promote consolidated sleep and reduce environmental arousals to get the best quality data possible. Older children, particularly adolescents, need to be assured of their privacy. They may not want the parent in their room, so you need to be cognizant of that. Encourage the parents to be supportive throughout the setup process and have them assist you as they can. Let's go on to our next slide. Okay, let's talk about our study performance. For pediatric polysomnograms, you want to have specially trained technologists, specially trained to work with pediatrics. Your staffing ratios need to be adapted to meet the special needs of this population, and that means there's highly likely you're going to need one-on-one care, especially with your infants and toddlers and your special needs groups. As you get to adolescents, your staffing ratios may be able to move back to 2-to-1, but with the toddlers, infants, and special needs, it's probably going to be more 1-to-1. For your setup and sleep preparation, expect a lengthier setup time, and go ahead and just plan extra time for this. Maintain a family-centered approach to meet the needs of the parent and the child. Again, encourage the parents to help in the hookup. And as you're hooking up, engage the child in activities that are distracting from the setup. Make it a game, make it something fun for them. Maybe they get to choose which color of electrode to put where, or where the next electrode's going to go, whatnot. Let's go on to our next slide. With our sleep disorder breathing, to assess alveolar hypoventilation in patients less than 13 years of age, we do use end-tidal CO2 monitoring or transcutaneous CO2. This is a requirement by the AASM, or a recommendation by the AASM. To assess behavioral observations, body positions, seizure activity, and parasomnias, we need to include digital video recording and audio monitoring. However, above all, one of the most important aspects of pediatric polysomnograms is the technologist documentation. Anything you see, even though it is being videotaped, you want to be able to document to keep a record. Let's go on to our next slide. Okay, so let's take a look at some unique factors in regards to the hookup with a pediatric patient. We do still use the International 1020 system for electrode placement. In order to determine correct electrode placement. However, when you are marking your spots on their head, you want to make sure you're using non-toxic, water-soluble color markers, and you might want to allow the child to choose the color just to make it fun for them. It gives them a sense of control of the situation, and it might help put them at ease. As far as preparing the scalp for electrode application, you want to gently scrub the intended electrode site with fine particle, mildly abrasive preparation product. Then wipe the skin clean with an alcohol pad and allow it to dry. You want to be sure to avoid the anterior fontanelle when prepping infants. So those are some factors as far as the electrode preparation. Once you do get your electrodes on, you might want to wrap the head in a piece of tubular stretch mesh, as you see in the picture here. Wrapping should not be excessive, as that create some undesirable effects, such as sweating and electrode popping, and then you're just creating more work for yourself. But this mesh material does allow better air circulation, and it keeps their head cooler, and you can see how they kind of made this one into just a little bit of a mask, so it just fits over their head nicely. You can also see they ponytail the electrodes, which most of us do with our adult patients anyway, but that does help prevent getting tangles and whatnot. Some other factors to consider with your patient's hookup, especially with your infants, is your placement of electrodes may need to be adjusted a little bit. Because of their smaller head size, you may need to use 6mm electrodes. Your distance between your chin EMG leads in small children might need to be reduced from 2 centimeters to 1 centimeter. The EOG electrodes may need to be placed 0.5 centimeters from the outer canthus as opposed to 1. Some other unique anatomy for infants that may require some adjustments include the snore sensor. Because of the baby's short neck, you might need to put the snore sensor on the top of their chest or high on their chest. Also, some infants, they don't really seem to have a waist to hold the belt on, so you might need to use a few pieces of tape to secure the belts in place. Those are just some examples of how your hookup might need to be adjusted for this special population. Let's go on to our next slide. Some other special considerations in regard to pediatric polysomnogram: allow the patient or the parent to sleep in the same room, maybe in a recliner or another bed, but not in bed with the child. Allow the parent to lay down with the child for soothing if necessary, but the parent should leave the bed once the child is relaxed and or asleep. If the parent's not allowed to sleep in the same room, assure them that the parent is close by and make sure they know exactly where they're going to be at. Videotape unsafe sleep practices demonstrated by the family during the sleep study, such as bottle propping or overbundling. This is helpful information for the physician and allows for better education to avoid things like that. Teach parents about the unsafe sleep practices and modifiable risk factors for the prevention of SIDS. For example, keeping the blankets away from their face when they lay them down to sleep, stuff like that. You want to test the patient in the supine position for the majority of the sleep study, so you want to encourage sleeping supine as well. Let's go on to our next slide. Sometimes the sleep techs just can't do it all, and you need to seek help with the sleep psychologist or child life specialist. This comes more into play when you're trying to help the child adapt to CPAP. The sleep psychologist or child life specialist can help provide desensitization when required, maybe working with the child and family and introducing desensitization techniques prior to the scheduled sleep study. They can assess whether or not the child will tolerate the sleep study. They can also help prepare the child in advance. And they are very good at assisting those patients who may have difficulty prior to a CPAP titration. So our sleep techs are awesome and can do a lot of things. Sometimes you just need to seek help from some of the child type specialists to help them with that. Let's go on to our next slide. Documentation during a PSG, I cannot stress how important this is, especially with our pediatric group. Behavioral observations during the study are critical in the interpretation of the pediatric PSG, so you want to make sure you document all behaviors: sucking thumbs, wiggling toes, rocking head, whatever it may be. Also, respiratory observations. If you see that they're doing some belly breathing, or if it looks like you're seeing increased accessory muscle use while they're sleeping, make sure you're documenting that. Quiet and non-REM sleep, active REM sleep, phasic behaviors. You want to document those as they appear. And as with any PSG, notation should be included anytime the study is interrupted or there's a change in the recording parameters, maybe if there's some artifact, if you go in and fix it, or maybe there's some artifact and you choose not to fix it. Make sure you're documenting what you're doing and why you're doing it. Let's go on to our next slide. Technologist interaction tips. The manner in which the tech approaches the child influences all aspects of the study. So you really want to make sure that your technologists are ready to interact with the age group. You do not want to treat the pediatric patients as a little adult. You want to use age-appropriate language, ask the child to assist in the setup, keep discussion of the process with the parent to a minimum. When with the child, you really want to be interacting with the child. Encourage the child to describe how the process feels. Allow the child to watch videos, listen to music, or play with a toy during setup and make it more of a game for them. Provide multiple opportunities for bathroom use as well. Let's go on to our next slide. Some keys to success for pediatric polysomnograms. One of the keys is advanced preparation. Based on the child's age, developmental stage, and special needs, Get the sleep lab and the environment and your process prepared in advance to meet those needs. Keep a family-centered approach, engage the child and the parent in the process, include pre-study education, provide a tour of your sleep center before the night of the study, engage the patient in the hookup process, make sure it's fun for them, use age-appropriate distractors. As far as running your study, you want to pay extra attention to securing your sensors before lights out. This will save you headache after headache if you do a good job with this. Maintain a high level of vigilance and responsiveness during the study. Recognition and replacement of dislodged sensors when appropriate. And what this is referring to is if the patient just fell asleep and an electrode goes bad and they took a long time to fall asleep, you may choose to just leave that electrode as is until the patient wakes up again. You may not want to disrupt them and waken them when you've struggled to get them asleep. And lastly, accurate documentation of your behavioral observations as well as any interactions or interruptions in the study. This concludes this PowerPoint.